pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Public comment. We have some folks here. Pat, would you like to address the board?
Yeah, do you want me to speak from here or up front, or what would be best?
Oh, from right there is fine.
Okay, to the members of the Lakeview Hospital Board and CEO Charlie Twiggs. It's come to my attention that the hospital administration has decided to lease space to Advantage Dental to place a mobile dental unit near or in the existing parking lot of the medical clinic area. Since this is the case, and since I've dealt with Advantage as a dentist employee and landlord, I would like to express my concerns and disappointment on what I feel is a very poor and improper decision. Number one, Advantage Dental is a corporate dental entity that is based in Redmond, Oregon. Although they employ local people and provide dental care to a very small percent of non-OHP and to all the OHP in Lake County, all profits, and believe me, they are significant, are returned to Advantage and its shareholders via their Redmond office. Hundreds of thousands of dollars, if not millions, are returned to their shareholders yearly of this private corporation. Virtually 99% of all profits are spent outside Lake County. This is obviously a for-profit, private, out-of-county corporation created to take advantage of state money, which pays no tax dollars to our county. Dollars are received from the state for each OHP patient on a monthly basis, whether the patient is seen or not seen, and whether they provide good care or not. Catering to this type of corporation is not and should not be something a tax-based community hospital should be doing. They have plenty of money to operate outside of the hospital area and benefit the community and downtown area without depending on and being catered to by a medical-based community hospital facility. By moving from a well-established dental building present in the Lakeview downtown area for 60-some years to a small mobile clinic, it will be hurting the downtown area since it will leave another empty building in the core area, and it will be hurting the patients since the provider space will be much too small to provide good and adequate care. The parking in the medical clinic area is inadequate now, and adding the mobile clinic will only make it worse. I have no idea with regard to plumbing, electrical, computer lines, and all that stuff that they require, how that's going to work. As their landlord for the past 5 years, I assure you they have had all the opportunity to renew their lease and or buy the existing building at a fair and reasonable price. But instead, they have purchased another downtown building, which they ultimately have decided not to use and leave vacant. And finally, due to a good deal from the hospital administration, have been granted a site on the hospital property. Unbelievable that the hospital administration, and I assume the board as well, has agreed to undermine the local downtown core area, patients, as well as myself as a local tax-paying citizen for 65 years. I am hurt and very upset by the decision. As a former employee and landlord of Advantage Dental, I have been lied to multiple times with regard to their intentions, with regard to the type and quality of patient care and materials they use, and they have failed to uphold their lease agreement according to the terms of the contract. The latter problem, which will most likely have to end in the legal world, and could very well be a problem for Lake District Hospital in the future. Myself and all my former employees ultimately had to terminate our employment with them due to the way we were treated. 2 months ago, I visited with Charlie, and 1 month ago with Don Litico, and informed them I had concerns with the hospital catering to Advantage. Both said at that time that there was no intention or plan to accommodate Advantage, and Don said he would let me know if anything changed. Although things have changed, neither person has had the common courtesy to communicate with me until confronted. I feel the rude and inconsiderate treatment I received from both to be inappropriate, as I had a much closer association with Advantage than anyone over the last 5 years, and should have been given time to share my knowledge and insight into my experience with Advantage prior to their decision. Although I support what Advantage is trying to do in principle, I cannot and will not support them as a good, competent organization. I feel the CEO and the board have made a poor decision, and one that is not in the best interest of Lake County. For the CEO of Lake District Hospital, I have lost all respect. Having dealt with his poor decisions regarding the nursing home and the care of my mother, the mandates he has placed on the local physicians, and now this, I am very disappointed. Moving forward, I feel the board and CEO should reevaluate the relationship with Advantage. Even though Advantage says it only wants temporary accommodations for the mobile unit, I have a hard time believing that. Due to their past lies to me and the fact that they have had over a year to develop their purchased downtown building into a dental clinic with nothing being done, I feel this is just a way for them to get their foot in the door. For good reasons, no other hospital in the state of Oregon or Idaho has ever provided for Advantage and their 38-plus clinics. That alone seems to be significant. I also might note that the Cascade Health Alliance in Klamath, who Advantage had their contract, who had contracted with Advantage to provide dental services, Advantage lost their contract with them last year. I also feel the board and CEO should do a better job of communication with the community and concerned citizens regarding any issues that potentially have an adverse effect on the community, the local downtown core area, and the citizens of this county. Possibly a community hearing, publication of a board agenda, and I looked at that this morning and I couldn't even bring it up. The last one printed was in August, it wouldn't even come up. Also maybe email notification to concerned citizens and other methods could be used. I'd like to thank you for your time. And I do have some copies here if you want to have those.
With the paper. Yes, sir.
Thank you, Pat.
You're welcome.
Are any other comments?
Well, I think you make a very good point about agendas being available, and they are not on the website.
We have had a lot of struggle with Fast Health and getting stuff uploaded and easily visible. So we are actually, Mallory's working on that aspect now, so trying to correct that.
Certainly something we are in the process of looking at whether or not we want to continue with them and have
Sounds
been
like-
working on that as an issue. Because it isn't, if you're not able to get that information, we should be able to have that readily available.
Right.
So,
And in regard to discussion of Advantage Dental, it was actually not on our agenda. It was part of your CEO report. So it was something that came up on at the meeting.
And no board action has been taken, is that correct?
No board action was taken. So, any other comment?
So whether or not board action been taken or not, certainly Advantage Dental has told me that they're definitely putting a mobile down here. So
I understand.
that's where I'm coming from.
Do you know when?
I'm thinking Charlie should know that since, he's the one that dealt with them. They told me, well, that it would be here in the October 15th, so that's what they told us.
the last email I got from them, it broke down. They were working on trying to get it filled. But I think October 15th is about the date that they hope to have it here. And as far as I know, it's a very temporary arrangement for them. They have it. I don't know what their business deals are. And that's, I think, what I shared with the board.
It is. Yeah.
Okay, well, moving on, if there's nothing else there, we'll go to approval of the consent agenda.
Thank you.
Thank you.
Thank you, Pat.
Move approval.
Second?
Moved and seconded to approve the consent agenda as presented. All those in favor?
Aye.
Passes unanimously. The August 2018 financial reports. Cheryl. Smile, Cheryl, when you do that. There you go.
So, did you get all the updated financials? It got better. Okay. So, overall, August was a fairly good month. It was a big improvement over July. It was, revenue-wise, it was good. Profit-wise, not as good. For the hospital, we had a total of 338 patients. Last year's average was 334, so it was very close to an average month. And year over year, the decline is in ED mainly, surgical outpatients, not really any surprises there. Ancillaries, again, no surprises, but a very strong month for lab and radiology. Rehab was good, home health was a little slow, and the health clinic was fairly busy again. So over last year, almost 200 more patients and 384 more lab exams. So that's all pretty good. Our gross charges for the month are right here. The charges were $3.175 million, well above our average last year of $2.9 million, so that's a good month. I think our numbers our colors are coming out a little bit easier to read. Good.
Thank you, Deb.
Our collections and AR, here is August right here. Collections were 1.8 million. They were below last year's average of 1.9, a little bit lower than could be, should be. September is quite a big bounce back. That was $2.38 million. So that's very good, and that's just collections on patient AR, so it doesn't include some of that quality incentive money that we got also, so that's not in here, so that's good to have a strong month. Our days in accounts receivable were 79, and they've dropped a few, or they were 82, sorry, and they dropped to 79 here in September. They're somewhat headed in the right direction. Do you want to talk anything about RICAN, about how it's going, where we're at?
Well, I think our collections are bouncing back because June and July were a little slow, because we're doing the implementation, so I'm happy with where our collections are. Our days could be better. I'm finding with RICAN, it's not performing like we expected it to, so I've reached out to them and I've got a contact at the top, because we've been dealing with RICAN just basically at the support case level, and we're not really getting the answers we need, and I find that we're touching accounts much more than we were before we had RICAN. For example, Medicare claims, we're touching 95% of them, and we didn't used to have to do that. It was less than 30% before. So I'm basically starting from scratch, because I got an email asking about getting RICAN for the clinic, and I was like, absolutely not, because it's not working within your group. Because if TrueBridge owns RICAN and CPSI and they can't make it work the way they say it's going to work, how can they do it with the clinical? So I'm really kind of holding their feet to the fire to get things set up. So next week I'll be meeting with my team and having a webinar, a WebEx with one of the top people that helped us set up RICAN. So hopefully we can get that resolved. They're just touching things more than they should, I think.
Keep plugging away.
I know.
Well, and my feeling is CPSI is working really hard at trying to convince us to stay with CPSI as our main software vendor. And what I want to say is, why would I do that?
Why? Yeah. Exactly.
I mean, if you guys really want to sell me on staying with you, you got to make this stuff work better, you know? That's kind of what I feel like.
So what's our alternative if we don't keep RICAN?
Just go back to the way it was. There are some things that we do like about RICAN. There's some things that are really awesome about RICAN, but just not all the claim touches. Like the girls are having to go into RICAN and then go back into CPSI and then go back into RICAN and then go back to CPSI. It doesn't make sense. Like, they're coming up with reminders that an account needs to be worked in RICAN, but a payment's already come in on it. And it was supposed to automatically cut out of their workies, and it's not. So I don't know if it's glitches that they can fix, or if it's just the way the system works, but the way I'm going to them is it's like, you say you've been in business doing this for over 20 years. We're not the first, this is not your first rodeo. Other people have faced these same issues. You need to tell me how to fix it. So you're not gonna like release it or giving this time.
Okay.
And it just points out the problem. Every time you change your ad software, there's a big
Yes.
delay in
Yeah.
getting things running
True.
smoothly.
It's true, and if we change to another main EMR, it will definitely have a big impact on billing and collections. There's almost no doubt about it. So I think it's getting better as the EMR industry matures, but it still very much exists. So the other thing that RICAN is not really doing is helping us discover, we need reporting that helps us understand where our problems are. So it's not telling us that. So there's a few problems. The days cash on hand in August were 70. In September, this is an estimate. I mean, days cash on hand, the calculation depends on your reconciled ending cash balances. It depends on your expenses for the months that you recorded. So I can't really give you a solid number. I do think that we're going to be much improved and close to where we need to be, but I'm not really going to know that for at least probably another 10 days. And I do think that the bank is going to, this is a month, since it's a quarter end, it's another bank measurement month that they're going to look
That does include the two incentive payments?
at. This estimate does.
Yeah.
Yeah, it includes all the incentive payments. And I think we've got them all now, so we're kind of done collecting.
And we have non-checking?
Well, there's one, there's still one outstanding, it's like 80,000, I think there's still one we haven't found, or haven't received yet, maybe. I don't know, I have to check that out.
Okay.
That's not gonna change our life. Okay. So then, our profit and loss. For July, our revenue was below budget, our expenses were below budget. Non-operating income was a bit above budget, our net loss for the month ended at $28,000. The error we had was in non-operating income, so the other stuff didn't change, we just had understated revenue in non-operating income. For the year to date, again, our revenue is under budget, and our expenses are under budget, and our non-operating income is a little bit above budget. Our loss for the 2 months into this year is $198,000. We budgeted to be at a positive 54, so we're behind by $250,000 at the end of this. Questions on it?
Just an observation, and I think it's pretty obvious that we're doing less business than we've done in past years in the acute care and those areas.
Yes, definitely, and it's an industry, it's a national industry trend that the length of stay is shortening. I mean, we're looking at same-day joint surgery for people, why not do distant future? So absolutely, and yet ancillaries continue to grow and outpatient surgery, so true.
And I don't think that's going to change. I think that's going to continue.
The key part of what I believe is that we need to try to capture more of the business that is leaving, because people are still getting services delivered. And that's how do we capture that. And we have some processes for dealing with it.
Charlie, if you looked at total services, ours plus wherever they go, do you have a way to do that and compare it to prior years? Are people getting healthier? That's the
No,
question.
they're not getting healthier. That's part of this Caravan ACO, is beginning to show us information on the Medicare population. Now, we look at the CCO information on the Medicaid population. It's harder on the commercial comparing, because we don't exactly know where they're going. Now with the Caravan information, their software is beginning to show us where the 600 seniors, it's not as many seniors as we have, it is a small portion of the population, but it is beginning to show us where people are going for care. And so if we can start figuring out what we can do to encourage people to have their care here, seniors here.
Because it shows where they're going, but does it show what type of care they're going for?
Yes. Yes. Yeah, it's very specific information. Now, there's a couple things that are going to change on it, and I've talked about this last month. The group that we were in is going to close, and we're actually getting into a bigger group. And last night, when I met with St. Charles people, they're in the exact same position. They joined the Caravan ACO for Central Oregon, the same time we did, January 1st, 2015. And they're getting wrapped into this instead of, in their cohort, it's predominantly Central Oregon because we're a little smaller and it took a lot of outside organizations. We're all getting wrapped into this bigger 200 community affordable care, or affordable care organization network. But we're still able to get the same information on our population. Okay? So the key part is, can we start understanding what's happening to our population? The first set of information that we got was partial information for 2017. And then we're starting to see information by quarter of 2018. Hasn't got it. On January 1, 2019, we will start seeing information on patients that are being seen by nurse practitioners or PAs. That was excluded in the first cohort. Okay? So that should potentially double our volume. The more people that we're looking at, the better idea of how realistic that is, where people are going, and what are they going for. It's not that there's always going to be people that are going to say, no, I'm going to have my services elsewhere, for whatever reason.
But Charlie, don't you have a pretty good idea, without all those surveys and all this and that, by talking to your friends and your neighbors and places you go yourself? You have a pretty good concept.
Some. I don't know if I'm confident in what I think. You know, part of what this is about to do is to help confirm what our beliefs are. Our beliefs may be accurate, and we may think we know what we're saying and where people are going, based on anecdotal descriptions. You know, I went there, but it's a lot of times it's the things that we don't, where people are going that we don't. And so I don't really know if I trust what I'm guessing to be true. Once we start seeing more detail, we will know that. And that's a big part of what the CCO has been able to start delivering for us, is much more accurate information on why and where people are going. So I hope to say, oh yeah, I was right. I just don't have the confidence yet. Okay? And frankly, what St. Charles folks said was they're in the same position. They think that preponderance of people in the Central Oregon, Deschutes, Jackson County, or not Jackson, the Central Oregon counties. Jefferson, thank you. And they think they know where people are going, the vast majority are staying. But there are still a lot of cases that we don't know about. And bit by bit, we're getting more either confirmation information or hopefully it'll be new information that'll say, gee, Merry Christmas, people are doing this for this kind of care. That would be great to know.
So the next thing would be environmental services equipment request. Charlie, you want to talk about that, or?
Oh, we want to do that, or we finished with?
It's on, well, it comes before you
Okay.
start.
All right. I don't know if we sent out to you the equipment request on environmental services.
We did not, because I did not get
We
that.
did
Because
not.
I came late with it, late.
So, when we brought Susan on, and Susan with Quentin have been working on evaluating the services that we're delivering in environmental services. And what we're finding is some of our equipment, we had planned that it would be needing to be replaced. But we're finding out there are some pieces of equipment, some floor cleaning equipment, some carpet cleaning equipment that isn't as good of a shape as it should be. And Susan is recommending that we purchase several different items. You have the list?
Yeah. Large floor scrubbers.
So a big component is floor scrubbers. We have had a floor scrubber for a long time. You may have seen them at night working. They're hard work. And so sometimes physicality is an issue. We can't always work it well. Became broke for whatever reason. We set it up for repair. It never came back to working the way it's supposed to. So our floors are not getting cleaned as well. So we need to replace that. And the total cost is about $25,000. We didn't plan on spending $25,000 on it. I think we had estimated
10
10
in the budget.
in the budget. And we thought that the repairs would make it stronger. Working out that. We also are finding that the carts that the staff are pushing around, they do carry chemicals. And as we have more and more people that might have access to those, I'm concerned about being able to block them and protect people from getting access to those chemicals. That means we need to upgrade the carts that we have to protect people from doing that. That's $5,000.
How many cars?
There are 6 carts. Now, that's not all of the carts. And that also includes, as we're moving into the clinics, some of that was what we should have anticipated, we didn't exactly estimate it. So we have to upgrade, but we have to add. It's a combination. So now that we have more space, we need to be able to have the equipment to move around from place to place. And there's now more carpeting. In the past, we didn't have quite as much, we have more space. So there's as part of the carpet portion, we have cleaning extractors for the carpet, not just the floors. And one sheet.
This,
Oh, no, I thought it was on the other side. So the carpet extractor for cleaning the carpets. You may have seen in some of those spaces, of just walking around, you're seeing spots in the carpet. Some of that will be replaced because it's during the construction period, the proposed. We need to maintain it there. And so that's the cleaning. So that's $4,200. So the total amount that we're asking to spend, we have budgeted, we are over budget. So we budgeted $10,000, it's $25,000.
That includes the carts and
big floor
Scrubber.
scrubber and a big carpet cleaner.
How much was the scrubber?
The big, that big, the big floor scrubber is like $9,900, but then you have to buy a $2,500 deck head and a $500 lid with tank rinsing system. So,
So that's your 10,000.
Yeah.
yeah, a little over 10,000. So,
So we'd like to ask board approval.
Hopefully, the repair and maintenance will go down, because we're not repairing old scrubbers.
true. And we can keep the old scrubber as like,
Back.
it doesn't work very well, but at least we have a backup.
Sometimes we wait until something breaks before we replace it. We don't necessarily, it's hard to plan that. When you are in a position where it makes sense to buy several all at once, you get a better price, but you have to buy a bunch at the same time. So you get something back.
The other question I would have is that oftentimes when you update equipment, you update the efficiency. Will this be the case with this machine?
So efficiency would mean we might need less staff. So part of that issue is we have taken on additional buildings that we're cleaning. And for example, in public health, cleaning was done on a contract basis. It's actually cheaper for us to have an employee cleaning that. It raises it to the standard of what we expect in a clinic. So we're still assessing. We're having a hard time finding people to fill the positions for right now. So I hope that we are more efficient. I expect that we will be. And Sue and Quentin are actively working on trying to be as efficient as they can.
There's another point to be made coming from a human resources standpoint. There have been injuries that take place because it's not very ergonomic and it's difficult to move it. It's quite large, it's heavy, and so this should help with injuries moving forward as well, operating that machinery.
Is that scrubber self-propelled?
You mean the Zamboni?
Do you have to push it or is it self-propelled?
Have you seen the Zamboni?
They push it.
They push
The
it?
new
Yeah,
one-
it's supposed to
The
be-
new one, I don't know if it's self-propelled.
It's self with assistance, but it is kind of like a self-moving lawnmower. It doesn't just exactly go on its own. It helps you, but, so, I don't know, I call it the Zamboni. It's not exactly.
So the total amount you're headed for is what, 35,000 something?
25,000.
25,000.
So 10 was budgeted, so
So we're 15 over.
over, yeah.
I would so move that the authorizations be approved as presented.
Been moved and seconded to okay the capital purchases for environmental services as outlined. All those in favor?
Aye.
Passes unanimously.
Thank you.
Okay, so quickly, Lakeview Gardens was like medical, health medical supply. We're in the process of changing the way we present the financials. We want to have, and I realized that we didn't do this month, so maybe I might even redo them again and send them out. But we did have the auditors here the week we were closing, so it was really, and it was a payroll week, and we were short a person, so it was really kind of a crazy week. So we get the ALF stats separated out here. So when you compare this 600, you have to, this 741, so 741 in total last August, but this August it's 601 and 173. So we had about 5 people in the ALF and about 18 in long-term care for the month of August. And then we'll try to break out that revenue, and maybe if you guys have any preferences, if there's something you want to see that you're not seeing, would you let me know, and I can add it to the worksheet, and we'll just see what it ends up being that you like the most.
So how many do we have in ALF now?
5.
5.
Well, you know,
Seven.
Yeah.
Seven.
That's as of September, no.
And as of
Continue to
today,
add.
we have 3 that we're interviewing next week, and we have 2 more that we're talking to.
Cheryl, in the numbers you gave us, it looked like we had almost $1 million write-off. What was that, something the auditors had us do?
In the,
well, I'll call it was contractual adjustments, what it was put down as.
In Lakeview Gardens?
Well, I think it was the gardens, if I remember right.
So, no, so first of all, you're not seeing anything that the auditors talked about. So when we decide, when they finish doing their audit, they'll send us adjusting journal entries, and then we'll actually apply those to June of last year. And it will change, I mean, it will change some of your balance sheet balances, that's true. But we didn't write off anything.
Well, it was in the, under the year-to-date numbers.
For the last 2 months, for July and August?
I'll
Yeah,
look it
let
up
me
and
know, because, I
let
mean,
you know
so
what
the
I'm
revenue
talking
we record is about 200,000 a month.
Yeah.
And contractuals for Lakeview Gardens are extremely low and sometimes negative because it's all Medicare, Medicaid.
Yeah, well, it was an odd entry, I'll get it.
Okay,
I'll
yeah,
get
let
it.
me know and we'll figure out what it was. No, so no, we didn't, for Lakeview Gardens. They had, their revenue was 209,000. So not a bad month revenue-wise, as we're starting to have more total patients than we had last year, or, prior years at this time. So our revenue was 200. What continues to kill us is the 86,000 we paid in contract labor, so that we had $312,000 worth of expenses and a loss of 102. And so year-to-date, we have a loss of $250,000.
Just a comment, I met one of the people who's in the assisted living facility, was having an outing to the Adel store with her son. She says, I like it there, I have one complaint. I've been there 4 weeks and I gained 3 pounds. She was very, very happy as was her son.
Well, we want people to try and maintain their weight, but sometimes change occurs.
Cool. Goose Lake Medical, they had revenue of, year-to-date of 94,000 last year. They had revenue of 76,000. Tony's there an extra day a week, so that's helping out. We're having a walk-in day, and that's been fairly popular. Expenses for August were 62, year-to-date 122, so we've lost 27,000. Year-to-date last year, we had lost 73,000 at this point. And can I talk about the letter later?
Talk about it right now. We received a response from CMS, if you recall, in our CHOP, which is the change of ownership process. It's gone through California. It then went to CMS. CMS today said it was received on September 10th. We have 30 working days to review and approve, or to respond. That is October 18th. Their response was, we will have it done by that day.
So how far retroactive will it go?
So when I talked to Eric, our auditor, and Katie Rabel from Quidco, they said we are sure of at least 1 year back. They said, I want to ensure that we petition them for the full half, because it has nothing to do with our delay. He said, I think we will petition like crazy. We believe it, but they don't want to take a position.
They guarantee that's the last hurdle, just wait till. And then,
They say that that's the last hurdle.
Did you hear any words of guarantee?
If it's any consolation, one of the companies that was trying to get our business today, that Nam and Susan and I were meeting with, said he's from the great state of Louisiana. And he said there is only one worse state in California, and that is Louisiana. So in terms of speediness, in terms of doing what they say they're doing. So that doesn't help us. But there appears to be light at the end of the tunnel. We don't think.
Train coming at us, you ever hear that?
Hope springs eternal.
And we'll meet them head on, right?
We will not.
Back them up.
We will not back down.
Okay.
DME, Lake Health Medical Supply, they had a net profit of $4,500 for the month, so they're just plugging right along. That's all I have to say about that.
At least somebody's making a profit.
But now we're next door selling some of that marijuana.
There appears to be, according to some of the people that I spoke with, one of our representatives, who said there seems to be an overabundance of the product in this state, and the owners of those establishments are having some financial difficulties.
Just a second.
Oh,
Just saying.
I don't know. Push the red. No, I don't think I turned it on.
Is that it, Cheryl?
Yes.
Okay.
No. Is it turned on? Yeah. But it won't.
It's supposed to like advance it, but that's okay, you can have it.
Okay. And all I can, okay.
Are you sure she's qualified to handle that equipment?
You can try there,
But
but
Marguerite
it
did
might
next
work.
weekend, don't show up. Are you gonna introduce me?
Okay. Personnel services update.
Yes, so I'm going to go through the presentation quickly because I'm told that you want it made quickly. And there's a lot of information, so if you'd like to review the slides, Jen can send that information out to you. Okay, so I tried to cut it down. There's quite a bit that goes into this new Oregon Pay Equity Act, and it's kind of been on the books since 2015. So I'm just going to go ahead and start. So basically, here, this is what it tells you, the Oregon Pay Equity Law, in a short synopsis. It covers all employees. Salary histories are prohibited now, asking those questions. We took those off our employment applications the first month I started working here in 2016, so we're in compliance. The employment posters, we've already got them ordered to be updated. And it basically, this prohibits discrimination. And that's, so wages, salary, bonuses, benefits, and equity-based compensation is all going to have an analysis. I've been given tons of formulas to be able to go through that. Now, there are some things that allow pay differences. There are 8 exceptions. I think I only have 6 here, but seniority of the location, education and training experience, and then we don't have piecework here.
Basically, we don't have to worry about the union contracts, right? We're just talking.
Yeah, no, we don't have to worry about the union contracts. But if we have non-union positions that are similar to the union positions, they need to be equitable, even if they're exempt from the union. So that does go into the formula, but we don't have a lot of those. All right, so there is a nice little thing that they've thrown in here that we have a safe harbor so that if we conduct this pay analysis every 3 years, it protects us. So that's a job for me to make sure that I have the documentation, the programs, all the steps that have been put in place. If anyone were to challenge it, that I would have the, a solid packet of documentation to present that we've done our due diligence. Why do we care? Because there's a perception that there's a pay in employment. I think everyone knows that. 78% of men agree, 60% of women agree. There's a pay gap, and it's not just with gender, it's also with, race, which we all know. Why is it important to us as an employer? Because your branding also has to do with how you pay people, because it's not only on social media, but it's word of mouth. So if it gets out there, most of you know that Amazon now is paying $15 across the board for their minimum wage. That is great branding, that is great pay equity, And that makes people want to apply for a position with you. In fact, last year they had 25,000 people apply for a position, they only had 2,500 openings. So that's pretty amazing. So diversity is also linked to employee loyalty. So if people of diversity see that we have pay equity and they will not be discriminated against, it increases your employee loyalty. Now we have a tough time because we're so remote. These are national statistics. But it does go into the equation because we will become more diverse, just slower than probably the rest of the nation. What can we do? We need to understand what's going on right now. You know, I need to dig deeper, look at what kind of programs we have in place. Not everybody has to have the same interview when they come in or job qualifications. What has happened in the past is departments have all asked the same questions in an interview process. That's one of the things that we don't do. We now specifically tailor them to the positions they're getting hired for. We want to change the fence. We want to look at how we're looking at the processes through the equity lens, our recruitment and hiring, our pay actions, our performance management, retention. All of these things go into the long-term plan. It's not just about money. It's about everything. So we want to look at the job qualifications and degree inflation because some of our jobs have been valued with just a high school diploma, but now they require a bachelor's degree, so those things need to be updated. One of the things is how we hire people. So if our employees get out and they make referrals, employee referrals have the highest rate of hiring sources. And here in our small community, it's really, really important. Word of mouth is huge. Along with that, we have to look at how we are paying people. This is just an example of a nurse supervisor. Before, it used to be that, you know, you got a percentage for, you know, how many years you've been in the job, your total tenure, but we need to include prior experience and education as well. So we have to look at updating those because those are very important. They do make a difference when you come with someone who has a bachelor's degree versus somebody that has a master's. There is a difference because they should have higher pay equity for that education. Employee retention programs, it's been shown that you have a lower attrition rate, so part of the pay equity program is developing retention programs. Also mentor and leadership development, that helps improve. You have to get it supported by your senior leadership, you have to have that buy-in, but having a mentor in a leadership development program has shown to help as well. So there are additional things, and then there's just a quote by Susan B. Anthony that I like, and this applies to everyone, not just women, is that you're in the service as a worker, not as your gender, race, orientation, whatever. So I like to keep that in mind. I've handed out a sheet with the Oregon pay equity law. Can you go back and pull up that?
We all got one.
So we handed out, this basically, January 1st, ultimately they would like to have all of these things accomplished, but when I went to my workshop, Bully had said, you know, there's going to be a grace period. As long as you're starting to work on all of these things, that's what they're going to look at because they know that it's a huge endeavor and undertaking. And we actually started on this after I came on board here. I started talking about the Pay Equity Act. But to everyone, it seemed like, oh, well, it's 2016, 2019 is far away. But when you look at the requirements of the Pay Equity Act, it's huge. So now I'm under the gun and have a lot of work to do to get this done. So I want to move on to, okay. So the cost of turnover, I didn't hand this out to you, but these numbers I want to preface by saying that they're from 2012. Okay, so these are old numbers. They're much higher now, but when you go on to find the data, it's really hard to find current data within the last 4 or 5 years. So these studies have been done, but the cost of turnover is much higher. For us, it can be higher because we are a remote location. So on the average, an entry-level position is about $3,500 to $4,000 when we have to replace somebody in turnover. Mid-level professionals can be anywhere from $7,000 to $15,000. Your senior executives can be anywhere from $25,000 to, if we have to replace a CEO, $250,000. So it's quite significant why we want to keep people here. If we know somebody's retiring, you can have a succession plan which will lower this. But if you get a resignation and you don't have time or you don't have applicants available, it increases your cost significantly. So across the board, it's 10 to 30% of an employee's annual salary depending on the position and turnover. So then there's the real costs, kind of like the soft costs. There's a recent article by Deloitte, and it came out that the cost of hiring a new employee will include advertising, all of that good stuff. You have the cost of onboarding and training. You've got a loss of productivity. They're saying it takes 1 to 2 years to reach productivity of the existing person. In my case, I would say that my learning curve is much higher. It's going to be probably 3 to 5 years. So, you've got a loss of engagement when there's a high turnover rate, especially in a small community. Then everybody starts talking and they say, oh, don't go work for that company. They're horrible. People quit all the time. So all of these things are really important. Customer service, errors that are made, and then training costs, because we invest training. There's ongoing training. And also it impacts us culturally. Whenever anyone leaves, everyone wants to know why did they leave. So these things are all important, which flows into, sorry, I'll let you navigate that. Our employee retention and referral and retention program that we just rolled out a week and a half ago. Oh, okay. Can I get just the program? Well, I don't know if you guys can see it from there, but so we developed a referral and retention program, and this is basically for our frontline staff. Yeah, a little bit. See, it gets weird, it keeps rolling. Sorry about that, technical difficulties. So basically, the philosophy is that great employees refer great future employees, and we want people to know that, our employees to know they're going to have a say in who gets hired by referring individuals. But on the flip side, we want to make sure that we reward our employees for bringing us good employees and helping coach and mentor them and keep them on board. So from the date of hire, if an employee refers a new employee, they get $100. If they make it through their 90-day period, their introductory period, they receive $150. But both the employee and the new employee get the bonus. 6 months, it's $250. 1 year, it's $5,000. So you have an opportunity.
500, I hope.
Oh, what did I say? Oh, I'm sorry, 500. No, I think I wanted the 5,000. Damn. So 1,000 total. And this is really a great incentive, and we've got, I can just kind of pass this around for you. We have employee instructions and then just little referral sheets, but I didn't want to print out them.
Leslie, if we had these rules
Yes?
a year ago, what would have been the incentives you paid out?
That I don't know, but I can tell you that starting because we just rolled out this program and it's for the people that have been hired or referred within the last 90 days. Now, the retention bonus also goes to a new employee unless there isn't some other retention bonus, like obviously for the nurses, it's quite more substantial and for our medical professionals. But these will touch mainly our CNAs, our EBS techs, our dietary, our administrative assistants, those types of people. So if we retain the 22 people that we have hired in the last 90 days, if we retain them for a year, I crunched the numbers because I knew you'd ask, we would save $41,000 in turnover. And that's using the low end of the stick. So it's a significant amount of money in my world. That could pay someone's salary and benefits, So I think it's a great program. So we rolled that all out, and yeah, that's what I've got. Any questions?
The employee referral, I think, is very well done. It's simple and very straightforward. So
Thank
that's
you.
going to keep, I think, a lot of people in the loop.
Well, when you
I
think
think that's
about
well done.
the entry-level wages for our frontline staff, $1,000 is a significant amount of money to receive over a year. In fact, the EBS techs, when they were presented with this, they all decided that they could just wear sandwich boards and walk up and down F Street and supplement their income. And so I've had both people very excited about it. I've had other people say, oh, why are we throwing all this money out there? Well, if you do the cost-benefit analysis, it will benefit us. And I mean, and if at some point we can, which I don't necessarily know will happen, but at some point we don't need to keep the program in place, then we'll discontinue it. But I really think all the added components with the mentoring program, the retention bonuses, looking at pay equity, all of that is kind of rolled into one big program. And you're not going to see it change overnight, but it will gradually make a huge difference. So, and especially so my team's really excited about it because then they'll have less work onboarding people. Because if you look at onboarding 22 people in the last 90 days, that's a lot of hours, not to mention the advertising, the interviewing, all of that. So it's very time consuming.
But thank you.
You're welcome.
Be careful with Amazon, the $15. They did away with their bonus programs and additional compensation, and they did away with their stock option programs and changed it. So there were some quid pro quo in there.
I didn't read the whole article, so I was just saying that is a good, on the surface, that gets people enticed on the surface.
PR job.
But if you're intelligent and you do your due diligence, you realize that that's not such a great deal.
There are some employees who are not happy.
Yeah.
But that's.
No, thank you. Good point.
But thank you for the, and the bonus program here is significant. I think that'll really help.
Let's see.
Yeah. See what happens. Okay, any other comments? Thank you. Construction update on the clinics and then the OR remodel. I think that's Mr. Twain.
So, last board meeting, I said, guess what, we're going to be able to move into the specialty clinic by the middle of October. A couple things have changed on that. And the bottom line is it probably will be, we'll be able to move into both facilities at the same time right before Thanksgiving. There's a couple of reasons for delays. One, they had some cabinetry issues that had to be redone in the specialty clinic. And what we also realized is all of the equipment that's ready to be put into the specialty clinic and to the expansion of the rural health clinic, it's all in the same pile of boxes. So it'll actually be easier to unpack it, assemble it, and then bring it to both clinics at the same time. So it's actually easier for our staff to do. That's the reason for the delay. So it isn't a negative, it actually is going to work out better for us. So we won't be moving in two phases, but one great big bang. And they're pretty confident they'll be able to meet before Thanksgiving time. I'll believe it when I see it. Just saying. So then, I think I sent out to all of the board members a report on the status of the borrowing, the money that we borrowed to build the Lakeview Gardens, then remodel the clinic, and then an estimate of where they think the clinic costs still are.
I didn't get that I recall.
I got it. I'm not sure that you sent it
I
there.
don't think so.
Okay, I'm sorry about that, I'll send that out. I thought I had sent it to everybody. And if we didn't, then it was partially because it's still in flux. So it's an estimate. So what it shows is as of our meeting last Thursday, or Wednesday, excuse me, last Wednesday, our construction meeting, they believe, they being Adroit, believes, and Cheryl and I have talked about these numbers to see if we think we're pretty accurate. They have about $430,000 in a total $14 million mark. But we have three more components to be considering and how we're going to use those dollars, or not. The things that we have to do is the parking lot. The parking lot that we said we didn't really want to do, but pretty much have to do, That's where Droid has their equipment right now. They're working construction camp and where they've been staging their equipment and work. What they did is, because they knew they were, well, that's where we talked about putting the parking lot, they brought in a great deal of rock to build up a solid base so that when they were moving the equipment around, it didn't sink in the mud during the winter months. They would normally have to pull that out after they leave that, but they also knew that's where the parking lot would go. So that helps to address the cost. If we do the ambulance building at the same time, then the cost of the parking lot would be $130,000. If they did it separate because of the grading issues, it's roughly going to be $150,000 if we don't do the ambulance component. We're trying to figure out, can we build an ambulance building at what we can afford? We have gotten a grant. I didn't bring that part up. Got a significant gift to be used toward that ambulance building. So that's in addition to the $350,000 that we received 2 years ago, last year. Last year.
2017.
So that was a very significant thing to be used toward it. So in either case, Detroit would not start construction until next spring. They don't have the capacity, and it doesn't make sense to be laying asphalt during the winter months. It would not have a good product. And they've tried to compare the cost of asphalt versus concrete, tried to balance the cost with what happens at Red Rocks and the road work that's been going on. We do have an asphalt plant here. We did not have that when we started the project for Lakeview Gardens. So those things all go toward the quality of the asphalt as well as the cost of the asphalt. Okay? So that's kind of the situation. So we're not quite yet ready to recommend to you this is what the cost for an EMS building would be. We have a pretty good idea of what the cost for the parking lot would be. So that's kind of an update of where we are with that. And there may be some unknowns that may still come up during this, but it appears that virtually everything is accounted for, and they're just buttoning up the last bits.
There's that asphalt that, Turs too, which actually last year was cheaper than buying from the local.
So one of the problems we got into with that is because of the drive, when they did the parking lot for the Lakeview Gardens, they ended up cutting out 3 sections because the asphalt had cooled or grading wasn't just, there were some complications. So when they look at price, but they also look at the quality of the product, that's part of that issue. And so they've been trying to think, yes, cost, and they're still estimating what they think it's going to be. But that's the latest that I've gotten from them as of a week ago. Okay? That brings us to the OR remodel. If you recall, when we brought on Dr. Skrinsky, we knew that we needed to add a sterilizer and a washing unit, pass through and make adjustments to that space. We have asked Detroit and ZCS Design, Architecture to design this. They couldn't get us an estimate, had problems with getting their subs. I finally received those cost estimates a week and a half ago, and then last Wednesday, this Monday, they revised it again based on Steris coming out and some adjustments. The cost is now $115,000. I emailed that to you this evening, so if you didn't see it, I apologize. I got it Monday I didn't get it out to you.
Did they kind of modify some of the building design too, besides, they had $10,000 worth of doors? It doesn't seem like we need to be changing doors.
So there are a couple things that we changed as part of this evaluation. One was we are moving the CRNA workspace to where our nurse, part nurse managers, so we have the OB nurse, Megan is there, plus we have some staffing positions. And they're going to have to move. We're anticipating putting them in the musical chairs process into where business office was. So that was part of the change. We have to move the automatic doors, and part of the estimate was, did they actually have to replace the doors or just move the doors? So there were a couple things that were adjusted based on that. Remember anything else, Teresa, in those changes?
I think so. Described it. It probably sounds a little confusing, but as you go into the surgery hallway, the surgery entrance, there's an office on your left. And then as you're going by that office, there's a set of doors that are always open. And those are the doors that we want to close and make the entrance. And then if you kept going, you'd come to what is now the entrance into surgery. And that would go away. And now that whole piece of hallway belongs to surgery and no longer gets used by the acute staff. It's a little bit confused you, but anyway, it's actually a really great way to give us more space in surgery, but it does require moving what are automatic and fire doors. So I think that's probably why it was more expensive than a regular door.
I'd be happy to show you on the plans. It's difficult to visualize without plans. And if we send you the small copies, it really works better when you look at it.
That one you sent us, the JPEG you sent us was,
Sorry.
it didn't work at all for me.
And so what I asked them to do was bring us hard copies so we could look at the paper and make sure that what we were talking about. And
So is that in the budget in any way?
we did not find it in our, it did not appear that we had it in our capital budget for this year. I think we were planning on it for last year, but we didn't add it. So what that means is we really have to do this, which means we have to hold off for something else. I think we couldn't estimate what the cost was because we couldn't get a number from the government. And they really, it's been frustrating, but to their excuse, all they can answer is, we haven't been able to get subs to even answer they would do the project. And since they're finishing up here, they have the plumbers, the electricians, can't come in and do the work.
So how likely is it we're going to have an orthopedic surgeon?
So we have two that we're working with, Dr. Dietrich and Dr. Brackett, Dr. Brackett. Both told me within the last 2 weeks they're submitting paperwork, they're still very interested. So they're not as quick to respond as we'd like, but I believe we're very close. Both have said, I'm still very interested, I want to be here. And Dr. Chang will begin on October, I think it's 15th.
It'll be the 15th to start
15th.
clinic on the 16th.
And he's the general surgeon that is working with Dr. Bradbury. So Bradbury's going to go to a 1 week a month. And Chang will be here 2 weeks.
He's the one who used to work at Burns, right?
That's correct.
Yes.
That's correct. And so we're expecting that we will be able to capture more cases than we've been able to with Dr. Bradbury being normal general surgeon. We think this will be very helpful for our community as well as provide a more comprehensive service. Right now, what happens for Dr. Bradbury is he gets slammed when he comes here because people have said, I want you to wait for this and this and this. And then he's very busy and it's hard for patients to wait and sometimes patients don't know. So we think this will be a good addition.
Good.
So I'm recommending that we move forward with the $115,000 water remodel expense.
What
And
do
if-
you think we are not going to do?
As long as we can find it where we're
We will
not.
find it, I can't answer that right now. We're going to, Cheryl and I were working on that. We'll come back with an answer.
But we'd still not exceed our budget.
There goes your salary. You're not getting any insurance.
If we,
Maybe I'll go out and hire somebody to work without me $1,000.
if you approve this, they would be able to start October 22.
And I was trying to read the timeline they had. When would they be finished?
Well, they're trying to they put in an estimate of 3 weeks. And it's not all at one time. We talked about trying to only do it when Dr. Sprinsky was not here, so that we didn't have any risk to patients. I mean, there was just a lot of, how do we figure this? And so Adroit gave us their best estimate of when they would do the project. And even this afternoon, one of the changes was they were trying to limit going into the hallway just to the north of that hallway just out here, so they didn't have to replace the flooring, so we were going to tap into the plumbing component.
3-inch drain versus a 4-inch drain.
So there were several things that they were
Yeah.
working on to try and make this, to accommodate us to the best of their ability.
This timeline says it'll be finished December 14th.
Some of it is, they start one part and then they, right up.
Is there any savings if our electrician does the electrical part?
I'm not sure if I can answer that off the top of my head. I'd have to talk with them about can we do that.
Well, I would make a motion that we move forward to $115,662 with this construction, and as long as we do not exceed our budget.
I second that.
Okay, been moved and seconded to approve the OR remodel up to $115,652 with respect to keeping it within our capital budget. All those in favor?
662.
662?
Yes.
Oh,
It should be in the documents that I did.
It is.
Great job for you. I did email it, but it was late, so I apologize.
Aye.
Aye.
all those in favor, say aye. It's approved unanimously. Medical staff update, Dr. Brennan is not here.
We did not have a quorum at our joint conference committee, so they did not approve anything. So when I asked him if he would be available, he had some, he was not able to be here. He thought he might be able to. So I was surprised that he didn't.
Okay. Well, we'll put it on next month's agenda. He might be at a rodeo somewhere. Okay.
Teresa's here. Yeah.
I didn't hear what you
I
said.
just said Teresa's here.
Yes, ma'am. So, we're going to have the nursing here.
Thank you.
Yes.
At least someone noticed.
Oh, you're not on the agenda?
I know.
You've been so patient.
I've been lost in Korea for 2 weeks, so I guess Charlie wasn't sure I was going to make it back.
That is correct.
North or south?
South.
I hope so.
Yeah.
She's
I'm
actually
not that brave.
secret diplomacy.
I'm not that brave. So I really only had one thing that that I could think of that was of interest. And we have been working on a revision of our programs for new hired nurses. And we kind of upped our game to be more like some of the other facilities. So we have the Rural Nurse Residency Program, which started today with Human Resources as one of the speakers. It's a program that will go 8 hours a week for 3 months. It includes a lot of information, training, as well as support. There's a lot of documentation, studies showing nurses who have more support during their first year of employment actually have greater retention and longevity at the facility. So we're trying to go for that. We have 7 nurses in that program. Some have already been working for us for 3 or 4 months, and some are brand new. And happily, 3 of those are coming, our first group of graduates out of the KCCRN program. So that's a wonderful thing, as well as the other nurses that are coming. So we are thinking that it's going well, and Amy Riches from our informatics department is shepherding the program and sort of acting as their connection. That way, it's a safe person who's outside of nursing that they can, talk with or discuss if there's any problems. So, so that started today, and I think it's got a good future.
You're aware that there's a matching grant opportunity of $50,000 for the Stacy Gainey Scholarship Program?
Patricia Gainey?
Patricia Gainey.
I think all of that came about when she was...
While you're not here.
While she wasn't here, because we've talked about the matching grant too, and how we need to get out there
I
and
need to
promote
get out
it.
and get a little bit more public. I didn't know.
For
if
nursing students.
Patricia Gainey for nursing students.
Right.
She doesn't know the money's gone.
Oh, I did hear that we were gonna try to put more money into that. I thought you were referring to, because we actually have Christy, our grant writer, working on a grant that looks really positive. I mean, who knows how it's gonna come out, but there's $500,000 out there for programs that are recognized as being innovative and improving your workforce. So we're working on that. That's what I was thinking you were talking about.
No, this is
This is a different program.
Okay, unless you have questions for me, that was the only thing I was going to know.
Stacy. Oh, yeah, okay. Well, I stand corrected. Thank you. Okay. Now, the CEO report, Mr. Phil.
So, since our last board meeting, I received an anonymous donor willing to match the grant program that you were talking about.
Right.
So that if people want to make donations up to, I believe it's $50,000, a significant amount for education for that very purpose. So this is very generous, and what we plan on doing is advising the public and trying to find other ways to find people willing to make donations for that very purpose, to meet this incredibly generous national grant. So keep working on that. So I told you that Dr. Chang will be here starting the 16th, 15th for orientation. So that's a very positive thing. I want to remind everyone that October 22 is our board training program in Burns, and it seemed a consensus that we would start early. So the 2-hour drive to get there by 8, try to leave from here about 7:30. said you might be.
I'll meet you in Berners.
What time though?
We will have coffee and a van to take everybody to. So this is a great opportunity to hear Jamie Orlikoff in I say. So then we will have on the 30th of October a strategic planning. So if you'll make sure you include that on your calendar. There's lots of things that we're talking about and moving forward. In our quest to try and identify what kind of system we want to use going forward for our electronic health record, we did have a presentation by St. Charles on their Epic system. That was the 18th of September. It has begun the process. We'll be having people going to different sites. The team going to look at how well the programs are working in the different locations. So we'll be coordinating that. We have been inundated with experts that want to advise us the best way to go. So there's a lot of moving parts on this. I'm not sure we're going to jump on that, but we'll see. It's hard to deal with cultural changes of an electronic health record because it becomes such a big part of how the system operates. But it is becoming more and more clear that we need to have an enterprise-wide electronic health record. So that means whether it's in the clinic, in the hospital, whether it's long-term care, home health, mental health, all the different places that we touch people, we need to have an enterprise-wide system.
It should be global, all the hospitals, all the clinics, and I'm sure we'll get there someday.
Things are progressing in that direction. And I think that if we look at how the industry is changing, there's getting fewer and fewer players, and smaller and smaller numbers of bigger and bigger players. So you want to try and figure out, is it going to be a platform that is used by lots and lots of people, or is the platform able to allow for connectivity with those other bigger systems? And there's some pros and cons. So we do.
Seems to me the state of Oregon tried that early on in the Affordable Care Act and spent $320 million to get interconnectivity between different programs.
Well, I'm not sure that they talked about trying to do things. I'm not sure that they've spent that kind of money. But there have been attempts to try and connect communities. We do have portions of our information systems talking to each other. A good example of that is the EDI program. So EDI stands for Emergency Department Information Exchange. In the states of, it's a software vendor based out of Idaho, or excuse me, out of Utah. And they connect Idaho, Washington, Oregon, parts of California. That allows for if a patient presents an emergency room, you can see if they've been to any other hospital in the last year or so. Now as the information is more important. Within a reach, so you could look for drug seekers, you could look for continuity of care issues, service. That is working. And there are efforts on a state level that the state has helped pay for some of that. And then there are other efforts to take that EDI program and bring that to clinics. So there's a lot of effort to try and find ways to have better connectivity. So we're continuing to evaluate that and try to come up with the best recommendation for the board. I met with the other two CEOs from California and the JPIA for California. And we're a little bit of a crossroads for a little bit. The chairman of the JPIA is a hospital board member from Mayor's Memorial in Fall River Meadows. he is getting off the board. And that the person who was the lay member is getting on their board. So we have 2 positions to fill. Both of the hospitals in California, not including Cedarville, are working on building constructions, and so that they've got a little bit of fatigue for trying to do network. They're asking if we could put the process of working together on hold for indeterminate time. They've all asked if the CEOs would meet. We believe that's a good, valuable opportunity for us to talk. But they're asking if it would be all right for us to put it on hold for a while, just because of fatigue. I think I would recommend that you consider it. Judy has been your representative on that board and has found some of it useful. But frankly, if I'm not driving it, it doesn't have a lot of air in the tires. And I just have had other things to focus on. Does anybody have any problem with that?
None whatsoever.
We are beginning a conversation with the school, with Will Cahill and several of the principals, about the possibility of having public health present in the schools, nurses. Not all the time, but that is a conversation that is exciting to be a part of and to see the change in the interest in it. So we're excited about that. We were trying to meet next week. We've already had one meeting. We'll be progressing. It'll probably be in about 2 weeks. So I'll keep you informed about how those discussions are going. Nurses in public health are very interested in this. Our staff in mental health are very interested in having practitioners from both organizations present in the school. The fact that the school's interested is just marvelous. So we already are seeing some involvement up in North and some of the involvement there. I have been in conversation with the Northlake Health District about renting space from them. We're in discussions they have built out their building to accommodate some of our mental health services, and that could be a positive thing for both them and for us. It'll be closer so we can have what's called a warm handoff between Northlake, or the Pine Clinic and the mental health practitioners. It would also be good to deal with the school system. If you recall, it's been not too long ago that we had tragedy occur up in Northlake, and our staff was able to be there and support the community, deal with tragedies. And we want to be creating teams to address that. So I'm very excited about those kind of changes.
Yeah, that's a good term.
It's an exceptional good term. So I'm very excited about it. I still hold my breath on some things, but getting done. Last week I've been at, the political issues are getting a little heated up in our county, in our state. Rather than address the county political issues, I have been in 2 different environments, one in Portland and also yesterday, and then to meet with our legislators to talk about rural hospital issues and concerns that we have. So our voice is being heard more and more. It's been pretty positive. So we'll see. It may not do exactly what we're asking, but it's positive.
There wasn't anything that really came out during legislative days in September.
So we're looking at what the governor's proposed budget would be, and looking at the shortfalls for the Medicaid budget and some of the factors that go into that. predict what will happen in the month, but it should be interesting.
In the governor's debate, the only one we've had, Governor Brown said she was going to put something in her budget for tuition forgiveness for mental health professionals in rural Oregon.
There's a lot of discussion about, and we can anticipate that there's going to be the legislative push to really support mental health services in rural. It's mental health services all over the state, but the challenges that hospitals are facing dealing with an increasing number of patients that are being warded in the emergency room. Last night, one of the examples that St. Charles gave is they had to get intervention by the governor because they had an adolescent who had spent 45 days in their emergency room. They could not find a place to put this adolescent. And that's just wrong. And so those are the kinds of issues that while we have had our share of challenges, other places have pretty big, significant challenges. And as a state, we're going to have to deal with it. So I think there'll be not only that kind of thing, but a lot of activity. And we want to be there prepared to be recipients so that we can continue expanding the services to our people. We're poised to be able to do that. That concludes my comments on what's happening. Do you have any questions of me or anything I can address? I do have some executive session.
What we'll do is we'll adjourn into executive session under ORS 192-660, bracket 2, bracket A personnel, bracket C medical staff, bracket H legal, and bracket J negotiations. And we'll take a 7-minute break and come back at 10 after.